to the next part to listen the experience sharing from Dr. Alan Fong. Welcome, Dr. Alan Fong, to share the case series of coronary angiography derived FFR with the flash angio CFFR system by Sarawak Heart Centre, Malaysia. Okay, welcome, Dr. Alan.
Good afternoon. Thank you very much for your kind introduction, Bob. And I'd like to take this opportunity first to thank our Director of Cardiology, Dr. Ong, for also providing us express permission to share our case series with all of you. I will be presenting this presentation together with my colleagues, Dr. Chandan Bhavnani and Dr. Genting Tan, who are cardiology colleagues who are specialized in the field of coronary imaging and physiology. Our center is the only public access tertiary cardiology center for Sarawak, Malaysia. Sarawak is approximately 125,000 square kilometers wide. It is about 1.5 times the size of the Czech Republic or 4 times the size of Belgium. We have a state population of approximately 2.8 million inhabitants with a life expectancy of approximately 75 years. We are a teaching hospital to the University Malaysia Sarawak and a cluster hospital to the Sarawak General Hospital, which is a major health Malaysia. Diagrammatically, you can see that we are at the star position, which is on the west coast of the island of Borneo, and it's about 1 hour's flight to Singapore, as well as 1.5 hours flight to the Malaysian capital of Kuala Lumpur. At our center, we have 5 consultant cardiologists, 2 consultant cardiothoracic surgeons, 2 consultant cardiac anesthetists, 3 cath labs performing over 1,000 PCI per year. We perform approximately 150 conventional FFR per year prior to 2019, using predominantly Abbott pressure wire system and the Assist RXI system. The history of the flash angio CA-FFR system began at the end of last year. Following the working visits from RainMed Medical to our center, this system became operational on the 16th of December 2019. This was a collaborative effort from the hospital as well as the local NGO, which is the Sarawak Heart Foundation, with the interest to improve cardiovascular care amongst our patients. To date, 66 examinations using the flash angio CA-FFR have been conducted, and mostly by Dr. Chandan Bhavnani. We'd like to thank all our colleagues for contributing to our efforts. And without further ado, I'd like to introduce Dr. Chandan to produce and present 4 cases of CA-FFR at our center. Dr. Chandan.
So good afternoon, everyone. My name is Chandan. Thank you to Dr. Alan for that kind introduction. I'm a cardiology fellow here at the Sarawak Heart Centre in Kuching, Malaysia. So I will be sharing 4 cases on how CA-FFR has aided us in the management of coronary artery disease in the cath lab. So the first case is that of a 48-year-old male, heavy smoker. He was admitted in late 2019 at one of our district centers for an inferior ST elevation MI. He was successfully thrombolized with intravenous tenecteplase. His echocardiogram at that time showed an ejection fraction of 52%. He was subsequently referred to us for an elective coronary angiogram. So as you can see in the coronary angiogram, the left main stem, LAD, and RCA arteries are normal. However, there is a 70% stenosis at the circumflex artery at the mid-segment. So we decided to do a CA-FFR on this artery, and the CA-FFR came up as 0.83, which is non-significant. So just out of interest, we also did an invasive FFR for this patient, and using a St. Jude pressure X wire, the resting PDPA across the circumflex lesion was 0.98. After 120 micrograms of adenosine, the PDPA was still 0.98. So in this patient, both the invasive and the CA-FFR were non-significant. So this patient had no further intervention done. He was discharged back to the referral center for optimization of medical therapy. We then called him up by phone a month later, and he was NYHA class 1, happy with medical therapy, and complained of no angina or hospitalizations. Moving on to case number 2. Case number 2 is a 52-year-old male, smoker, dyslipidemic. This patient was also referred to us from a district center with a history of an anterior ST elevation MI in October last year, successfully thrombolized. This patient's ejection fraction was between 30 and 35% post-AMI. His angiogram done in late December 2019 showed a normal LMS, minor disease in the circumflex and the right coronary artery. However, in the LAD artery, there are 2 discrete lesions, one at the very proximal segment of the LAD of about 70%, and also one at the mid-segment of about 50 to 60%. So we decided to do a CA-FFR on this patient as well. The CA-FFR down the LAD artery on this patient was very significant at 0.54. If you notice the diagram as well, we noted a significant drop in the FFR, especially across the proximal LAD lesion. So we knew we had to treat both the proximal and the mid-LAD lesion. So we decided to predilate both lesions with initially an SC semi-compliant balloon, 2.5 by 12 mm balloon. After treating both lesions, we noted a residual stenosis of only 20%, and we noted TIMI3 flow down the LAD artery as well. So we decided to repeat the CA-FFR down the LAD. So a repeat CA-FFR showed a significant increase from 0.54 to now 0.83, which is a significant increase in the CA-FFR after the balloon dilatation. This allowed us to embark upon a DCB strategy, a drug-coated balloon strategy, which we used for the proximal LAD with a 3.0 14 Impact Falcon DCB and a 2.5 30 for the mid-LAD. As you can see, the final angiogram showed acceptable results. There is a type B dissection at the mid-LAD. However, the flow is TIMI3, and the patient was very comfortable and the vital signs were stable. So we left the lesion alone and allowed him to go home. We called him up 1 month post-procedure, and again, this patient was very comfortable. He had no symptoms of angina, and he had no hospitalizations to the district hospital. Moving on to case number 3. Case number 3 is a 51-year-old male from Bintulu, Sarawak, which is about 900 kilometers from our center. He is a hypertensive, diabetic on oral hypoglycemics and insulin, dyslipidemic, and a reformed smoker. He had a history of an inferior STEMI in July 2018, for which he was thrombolized with intravenous streptokinase. He was referred to us subsequently for a coronary angiogram. So his coronary angiogram revealed very severe coronary artery disease. We noted a normal left main stem, 70% stenosis at the mid-segment of the LAD, an occluded proximal circumflex, and also a subtotally occluded RCA. So this patient had a normal resting echo at the time. So in this scenario in our center, after discussion with the patient in view of his type 2 diabetes, he was offered option of a CABG, a coronary artery bypass graft, for which he was agreeable and keen. Unfortunately, our waiting list for CABG is rather long. So his tentative date for surgery was 18 months after the angiogram, as there were no earlier operation dates available. However, because he was asymptomatic, he was happy with medical therapy, so we continued the same for the time being. When we reviewed him back at our center almost a year later, in January 2020, he was still completely asymptomatic. And at this point, the patient did not want surgery, as he had been waiting for a long time. And he was very happy with medical therapy. So because he wanted to be taken off the surgical wait list, our cardiothoracic colleagues requested for a relook angiogram to see if there was any progression in his disease. So we repeated an angiogram in late January 2020, which is almost a year and a half after the index angiogram. And as you can see, the LAD artery looks almost the same stenosis in the proximal and mid segments. The circumflex, of course, was occluded, and the RCA was occluded as well, as per the original angiogram. So we decided to do a CA-FFR down the LAD artery to assess its significance. So the CA-FFR down the LAD came back to be 0.73, which was quite significant. So again, for this patient, for completion's sake, we decided to compare it to an invasive wired FFR. So the wired FFR, resting FFR down the LAD was 0.84. And after a total of 120 micrograms of adenosine, the PDPA came down to 0.67, which was also very significant. So this patient gave us a diagnostic dilemma because he had no events since his AMI. His angiogram showed no progression in disease for the last 18 months. However, his CA-FFR and his wired FFR showed a very significant LAD territory for ischemia. So we convinced him to go back to see the surgical colleagues, which he was agreeable to. He then ended up having his surgery done on the 1st of March, uneventfully. And when we called him up 2 weeks after his surgery, he was very comfortable. He was angina-free and was NYHA1. Moving on to our last case for the day. This gentleman is a very young 27-year-old male. He is a smoker and a newly diagnosed diabetic as well. This gentleman was referred to us for an inferior STEMI, for which he was thrombolized successfully in December 2019. His resting echo on arrival to our center showed a normal LV ejection fraction with some posterior and inferior wall hypokinesia. His angiogram showed a normal left coronary artery system. However, as you can see on the right coronary artery, there is a stenosis of about 60% at the mid-segment. So we decided to do a CA-FFR for this patient as well. So the CA-FFR for this patient came back to be 0.87, meaning that the lesion is not significant. So for this patient, as the patient was young and was asymptomatic during the procedure, and the CA-FFR was 0.87, we decided to medically manage it, and no intervention was performed. And this patient, again, we called back a month after the procedure, and on discussion with the patient, he had no more chest pain, and he was NYHA1, and he had gone back to his routine day-to-day activity. So with this, thank you very much.
Okay, thanks, Dr. Shannon, and thanks for Dr. Alan's sharing and the excellent speech. Okay, there are several questions about the cases shown, and the first one from Paul. Dr. Shannon, the first one is, in case 2, can the FFR separate and predict the 2 lesion ischemia separately?
Yes, so the CA-FFR across the first lesion was much more significant than across the second lesion. If I'm not mistaken, the drop across the first lesion went down to 0.40. And then the FFR actually picked up between the first and second lesion. So I think it was able to help us identify that the proximal lesion was more severe than the distal lesion.
Okay, thanks. Another question. I think you can see the question also in the studio T3. If you could do retrospective CFFR and it was abnormal, could have spared him a repeat angiogram.
Regrettably, we cannot do a retrospective CA-FFR yet, as it requires real-time aortic blood pressure monitoring. So we could not go back and analyze his blood vessels using the first angiogram. So it necessitated a second procedure for him.
Okay, thanks the answer for Paul. Okay, any other questions for the speech and presentation from Dr. Chandler and Dr. Alan? Oh, someone maybe click wrong just now. And any question or something you want to communicate with Dr. Alan and Dr. Chandler? Please drop your question here, or you can open your microphone directly.
Can I make a comment, Bob?
Yeah, of course, please.
Yeah, in Malaysia, the National Heart Association, which is our cardiology professional body, published the local appropriate use guidelines for coronary intervention and revascularization. In stable coronary artery disease, physiological assessment of stenosis becomes a very important component of how we decide on revascularization strategy. In the local environment, it is the reason why we have taken physiological assessment more seriously, and having additional technologies such as fractional flow reserve will provide us more information in both risk stratification and prognostication of how we look at coronary stenosis. Of course, this remains very new compared to having conventional wired FFR, but we look forward to having more FFR assessments to help us make appropriate management decisions for our patients with coronary artery disease. I think as such, we are very grateful for the opportunity to participate in this session and to share the experience of flash angio CFFR at the very beginning for the last 6 months. Clearly, a lot of the case for coronary angiography has dropped during the last few months due to coronavirus, but we anticipate greater referrals, a higher number of referrals to our center, and we believe that fractional flow reserve will provide us a more important objective measurement of coronary stenosis beyond conventional methods of assessing FFR. On the question of how we handle the FFR during the procedure, we can actually do it in completion from inside the cath lab. I think the operational aspect of it is quite easy, provided there is familiarity with the system. I think it's very similar to all the other intracoronary imaging and physiology systems that we have. So for Dr. Ostrowski, that I hope can answer your question.